Hello, my name is Samantha McCoskey. I'm with the Department of Graduate Nursing at St. Mary the Woods College. The current course we are in is Clinical Management 1 in U540, and my presentation is over syncope. Some of the objectives of this presentation are the review of a concept map, presenting a real case study, analyzing risk factors, explaining the pathophysiological mechanism, evaluating diagnostic approaches, and reflecting on management and treatment strategies. Syncope is a loss of consciousness that occurs abruptly as a discrete episode and usually lasts for a short period of only a few minutes. It is quite common among both genders and people of all ages and is often caused by medical conditions. These could be cardiovascular diseases, neurological problems, or even metabolic abnormalities, which in one way or the other affect the occurrence of syncope. Proper diagnosis is needed because syncope can present as a single episode or as a symptom of a severe disease. The concept map that's included in the presentation will include risk factors, clinical diagnostic presentation, and therapeutic approaches that is useful in handling patients with this diagnosis. The following concept map gives an organized approach to syncope. This will assist in understanding the major components of the problem, the risk factors, mechanism of clinical manifestations, diagnostic criteria, as well as the approach of treatment. Knowing these components regarding syncope management in the clinical setting is crucial. We will then look at various causes of syncope, such as cardiovascular problems, arrhythmias, neurological conditions, and metabolic disorders. Knowledge of these factors is important in the patient's evaluation to recognize candidates for such complications and design a diagnostic and treatment plan for these individuals. We will also briefly talk about the pathophysiology, which relates to the origin of these symptoms that contribute to a downward shift in the cerebral blood flow in syncope. The concept map for syncope is divided into 5 key areas: risk factors, pathophysiology of the disease, signs and symptoms, diagnostic strategy, and therapeutic management. The risk factors help define subjects who can develop syncope, including cardiovascular, neurological alterations, metabolic, and even environmental conditions. Cardiac disorders, including arrhythmias and structural disease of the heart, as well as acute myocardial infarction, affect normal blood circulation and especially cerebral perfusion, leading to syncope. Neurological causes of syncope include stroke, TIAs, and seizures, since they affect the blood supply to the brain of a patient. Disturbances in the metabolic state, that is the state of the balance of the body, often lead to syncope as the body's equilibrium is affected. These risks are intensified by conditions such as postural hypotension, that is due to prolonged standing, exposure to heat, or exhaustion. Risk factors associated with syncope are related to the pathophysiological process, and these factors are classified into cardiac, neurogenic, and orthostatic syncope. Some of the cardiovascular causes include arrhythmias, which causes non-efficient pumping of blood in the heart, and obstructive cardiomyopathy, in which blood supply is restricted and the brain is also affected. Neurogenic causes. The most common of such causes is vasovagal syncope, which occurs when the vagal nerve responds too actively, causing the blood pressure to drop and the heart rate to slow down, hence reducing blood flow to the brain. Orthostatic syncope is a common clinical condition that is characterized by the inability of the circulatory system to adjust to positional changes. and decreases blood pressure perfusion of the brain. The symptoms can be split into pre-syncopal, syncopal, and post-syncopal categories, and this has widely been adopted by healthcare providers. The conditions that precede syncope are dizziness, numbness, tingling sensations, lightheaded, blurred vision, and palpitations. A syncopal episode is characterized by a transient loss of consciousness and muscle tone that is usually of brief duration and self-resolving. The post-symptoms may include fatigue, lethargy, headaches, and sometimes a fall-related injury that points to the fact that a broad differential should be pursued in patients who present with syncope. Some of the diagnostic criteria of syncope are physical examination, which and also diagnostic activities can be counted as triggers, frequency, and the presence of other symptoms. Measurement of orthostatic blood pressure to exclude orthostatic hypotension, and an ECG to diagnose arrhythmias. Additionally, testing such as echocardiogram, tilt table test, and Holter monitoring if outpatient, and telemetry monitoring if inpatient may be used in order to establish other underlying causes. So lastly, on the concept map, guideline-based treatment emphasizes establishing the reversing the syncope's cause. Lifestyle measures may be taken into account to include more water intake, avoiding and increasing salt intake to increase the blood flow in the body, avoiding triggers, precipitating factors for the syncope, and sometimes pharmacological therapy with beta blockers or midodrine in the case of vasovagal or orthostatic syncope. In more severe cases, even surgical treatment such as implantation of a pacemaker may be required. So my case study involves a 65-year-old male who was brought to the emergency department after experiencing something um, while standing in line for groceries. So his symptoms included dizziness that he had felt, which made him unconscious for just a brief time. He stated that he did not feel any chest pain before the occurrence. His past medical history consists of hypertension, type 2 diabetes, and coronary artery disease. The patient currently takes metformin, lisinopril, and baby aspirin daily. During physical examination, the patient's vital signs are within normal limits, but he does experience a drop in blood pressure upon standing. So the doctor assesses the patient through physical examination, an ECG, echocardiogram, and a tilt table test. Both the ECG and echo are normal, but the tilt table revealed a vasovagal syncope. So the physical examination is critical to get information regarding the patient's general health status and to evaluate the possibilities for the root cause of the syncopal episode. So with examining, there's close monitoring of vital signs, orthostatic examination, cardiovascular and neurovascular examination to understand any deficits or factors that may have contributed to the syncopal episode. So this patient's vitals, blood pressure was normal at 110/70, heart rate was 75, respirations were 16, and oxygen level was 98% on room air. But then orthostatic vitals, blood pressure lowered to 90/60 with a corresponding increase in pulse rate to 90 beats per minute in the standing position. The cardiovascular exam, the rhythm was steady without any changes, and the ECG indicates normal sinus rhythm. The neurological exam There were no abnormalities in the cranial nerves, strength, and tendon reflexes. Patient is fully oriented and speaks normally and is following all commands. He is not lethargic and has no neurological abnormality on exam. So the ECG study showed normal sinus rhythm with ischemia. It is reassuring as other factors, including acute myocardial infarction or abrupt variations of heart rhythm, can be ruled out as the direct reason for syncope. Then the echocardiogram was also normal. What this essentially means is that the wall and pumping function of the heart remains intact, eliminating um, that this was caused by a structural heart disease as a reason. The most informative test for this patient was the tilt table test. This was beneficial to vasovagal syncope. The outcome suggested that the patient's fainting as a result of low blood pressure and slowed heart rate when standing or within a few minutes of standing. Blood tests were within normal range for glucose, electrolytes, and hemoglobin. This would have ruled out any metabolic causes for low glycemic or low potassium. All the testing that this particular patient for the case study, pointed to vasovagal syncope with an underlying feature of orthostatic hypotension. So lifestyle adjustments and others other things could be done for this patient, but lifestyle management and adjustments would be the most important. One of the things I did want to talk about, some of the most cost-effective testing for this type of diagnosis is just that, the orthostatic blood pressure, the ECG, the telemetry if the patient is admitted to the hospital, and if outpatient, an ambulatory monitor such as a Holter monitor. Not cost-effective testing, but sometimes indicated, would be a head CT, a brain MRI, an EEG, echocardiogram, carotid ultrasound, stress testing, and cardiac enzymes. So diagnosis and management. So in this case study, this patient was revealed to be suffering from a vasovagal syncope and the risk factor associated with orthostatic hypotension. Pharmacological methods would be avoided at first, and we would want to treat any underlying causes, being conscious of triggers and explaining the need to avoid them, drinking adequate amounts of fluid to stay hydrated, and adding the appropriate amount of salt intake, because that will increase the blood volume in the body. Treating any type of hormonal and or electrolyte imbalances would also be um, a good way to um, manage these episodes. Pharmacological management, if needed, would be the use of midodrine. I don't know if I'm saying that right, at 50 milligrams every 12 hours. And then upon evaluation by PCP after being on this medicine, it could also be adjusted and increased if needed. After the interventions, the patient should always follow up with PCP, whether they're non-pharmacological or pharmacological, to monitor the response to the treatment plan. The patient should avoid exposure to the triggers and adhere to adequate fluid and salt intake. At the same time, it's also necessary to pay attention to monitoring of adverse effects and drug interaction with the use of the midodrine if that is something that the primary care doctor and the patient decide on. So my review questions for this are: what are some of the diagnostic measures for symptoms of syncope? What is the medication of choice for syncope? Should non-pharmacological interventions fail? And why do you want to increase fluid and salt intake if diagnosed with syncope?